Eric Klein. I'm chairman of the Glickman Urological and Kidney Institute at the Cleveland Clinic.
Dr. Klein, you have been significantly involved in most of the recent prostate cancer prevention research over the past decade. What do you think we have learned to date?
Boy, we've learned a lot from the prevention trials. From the prostate cancer prevention trial, we learned in the placebo arm, in fact, that PSA is not the marker that we thought it was in terms of detecting cancer, and that there's no specific cutoff for PSA below which the risk of getting prostate cancer is zero. And that's led to the development by Dr. Thompson and his colleagues, not with my involvement, to develop a prostate cancer risk calculator that allows us to determine for an individual man what his risk of overall prostate cancer is and what his risk of high-grade disease is, which is more important in today's era, where low-risk tumors generally probably don't need to be treated or certainly can be followed for a short period of time, and high-risk tumors or higher-grade tumors we want to treat immediately. So that's been one thing that's very useful. A second thing we've learned is the effect of 5-alpha reductase inhibitors, both finasteride and we think dutasteride, based on the data published at the AUA, that they reduce the risk of a man getting prostate cancer by about 25%. And that's the main scientific finding from the prostate cancer prevention trial and the REDUCE trial. We also learned that finasteride increases the diagnostic accuracy of PSA, so that a man who takes finasteride, it makes PSA a better screening test. And that's another advance. I think those are probably the three major important aspects from those two big trials.
Do you believe there are definable groups of patients who should be receiving treatment with a 5-alpha reductase inhibitor such as finasteride or dutasteride to prevent prostate cancer? If so, who are they?
Now, there's a current debate in the community, I think, about what the clinical utility of finasteride or dutasteride are. If you take the REDUCE trial at face value, it really should only be used in men who had what we thought previously was an elevated PSA between 2 and 10 and a negative biopsy. That's what it showed, that it reduces the risk of prostate cancer in men by 25%. The bigger issue, though, is for the average man in your clinic who walks in the first time, maybe with a family history of prostate cancer, a PSA in the upper 2s or low 3s, is that someone who should be subjected to the potential downsides of these agents? And the answer isn't clear yet. I think there's discussion ongoing now to, rather than use it broadly across the entire population of men, is to try and better identify who's at highest risk, because men at highest risk are the ones who will gain the most benefit from the use of these agents. And so the AUA, for example, in its new PSA guidelines, best practice guidelines, suggest a baseline PSA on men in their 40s. I think that's a great idea, not because we want to find prostate cancer in 40-year-old men, but simply because the absolute value of PSA in your 40s is a good predictor of your lifetime risk of prostate cancer. So it turns out that, let's say you have a PSA when you're 45, if you're above the mean of the population, which is about 0.7, then you're close to at least a 10% lifetime risk of prostate cancer. Well, one could think about that and argue that taking an agent like one of the 5-alpha reductase inhibitors that reduces your risk by 25% would be a substantial benefit to that population. We need better markers, and in particular better genetic markers, to help predict the lifetime risk of prostate cancer. Once we can identify a really high-risk group, I think use of these agents will increase substantially.
Can you give us an update on the current status of the REDEEM trial that is comparing dutasteride treatment to expectant management for low-risk prostate cancer? When are the results of this trial now expected?
The REDEEM trial is a randomized trial in men on active surveillance between dutasteride and placebo. It is fully accrued, and I don't know when the results will be reported. It really depends on the event rate. The idea there was to reduce the likelihood of a man on surveillance getting some intervention by about 50%. And so it really depends on how many men during the course of the trial actually go on to treatment, particularly in the placebo arm. So it's probably going to be a few more years before we know the answer.
Are you expecting to see a major trial of a statin to prevent prostate cancer? Do you think that doing such a trial is justifiable?
Yeah, the statin story is very interesting. There's some interesting science behind it. Statins are anti-inflammatory agents, at least in part, and there's a substantial amount of biologic and clinical evidence to suggest that inflammation is important in the development of prostate cancer. So it has some theoretic appeal. Statins also reduce the risk, not reduce the risk, but lower serum PSAs by a potentially clinically meaningful amount. And so we're not sure if that's an interference with the assay or the statin binding with the PSA in the blood, or whether it's a reflection of cutting down the inflammation in the prostate so less PSA leaks out, or whether statins could have a direct anti-cancer effect. It's an interesting observation. Thirdly, statins are interesting because there are two large epidemiologic trials that show that use of statin reduces the risk of having advanced metastatic prostate cancer. And it's dose and time dependent, so it makes biologic sense. The longer you take an agent, the more benefit you get from it. Another interesting observation is that there is some genetic evidence and some clinical evidence to suggest that inflammation underlies both prostate cancer and coronary artery disease. And so they might, at this sort of biologic final pathway in terms of an inflammatory response to inflammation, perhaps to an infectious agent in each case, that statins could be helpful there. So it's interesting. There is some discussion in some of the large cooperative groups to look at statins in the active surveillance cohort, like the REDEEM trial. I suspect, given the negative results of SELECT, that large government agencies are not going to be willing to invest large sums of money to do a large-scale chemoprevention trial with statins just for prostate cancer. We probably won't see that.
What percentage of patients managed at the Cleveland Clinic are currently being managed with active surveillance or expectant management? And is this significantly more common today than, say, 5 years ago?
Yeah, there's no question that the number of patients undergoing active surveillance has increased substantially in the last few years. We have almost 500 patients in our department on active surveillance, and what percentage of our patients that represents, I don't know. If you look at the CAPTURE data going back a few years, only about 10% of men or fewer, even with low-grade cancer, especially with low-grade cancer, actually choose a surveillance protocol rather than treatment. That's a real challenge. There's no question that we need to be able to better answer a patient's question at the time of diagnosis, do I need treatment? We currently don't really have the clinical or biologic markers that allow us to do that with enough accuracy. And so men respond to that uncertainty by saying, gee, if my doctor's not sure about this, if there's any chance, even if it's small, that this cancer could metastasize or kill me, that I want to have treatment. So about 90 to 95% of men who might otherwise be eligible for surveillance in the U.S. actually get treated.
Can you tell us about the SELECT trial?
Yeah, I should comment on the SELECT trial, which I helped run with Scott Glickman at MD Anderson. This was a large-scale chemoprevention trial in 36,000 men looking to see if selenium or vitamin E alone or in combination could prevent prostate cancer. And some people have called it a failed experiment. I would characterize it by saying it was a great experiment that had a negative result. And in essence, we showed that neither of these agents prevent the risk of prostate cancer, nor do they lower the risk of colon or lung cancer, nor do they increase someone's chance of living longer. And so the trial pretty definitively answered the question that these agents are not useful in preventing any of those major outcomes.